Good morning, good afternoon, good evening, everybody. Welcome to the webinar. We're waiting for a couple more minutes for additional attendees to join us, but in the meantime, I just wanted to say a quick hello and welcome. My name is Kerry Albright. I'm the Chief of Research Facilitation and Knowledge Management here at UNICEF's Office of Research in Achenti. This is the second webinar in our series of Best of UNICEF Research and Evaluation 2020 winners. The first of our winners from the research side. I will introduce you as people come in to speak, giving a little bit more detail about their biographies before the presentations. But in the meantime, just to tell you quickly who we have with us here today. So we have, in addition to myself, we have Manti Chikombero, who is a Communication for Development Specialist with UNICEF Uganda. We have Assistant Commissioner Tablé Bakiata from the Uganda Ministry of Health. Hopefully also will be joined by our colleague Richard Kabanda from the Ministry of Health, but Tablé is going to speak on his behalf if not. We also have a colleague, Benjamin Hickler, who is a Behavioral Science Research Specialist at the UNICEF Office of Research in Achenti. But first of all, to kick us off, I'm going to introduce you to another colleague, Gunilla Olsen, who is also from UNICEF's Office of Research in Achenti. Gunilla was appointed as the director of that office just last year, but she has a long and very illustrious career, both across UNICEF, across many other UN agencies, and also from her hometown, her home Ministry of Foreign Affairs in Sweden. So for some official opening remarks, I'd like to hand over to Gunilla, and welcome again. Thank you.
Thank you very much, and thank you so much, Kerry, for inviting me and for the kind introduction. And let me start by saying a word about the Best of UNICEF Research and Evaluation, or BOR and BORE today. For the past 80 years, the Office of Research in Achenti has invited UNICEF colleagues from around the world, country offices, regional offices, national committees and headquarters, to submit their best and most recent examples of quality research for children. The aim is to promote research best practices, to identify where they may be scaled up, and to award quality studies with a high potential for impact on policies and programs that benefit children. The 4 years I served as the representative of UNICEF in Indonesia, I did see how BOR was providing both a great incentive to do good research and a huge recognition for my team as runners-up or as winners. In 2020, UNICEF in Achenti and the Evaluation Office joined forces to produce a single report, the Best of UNICEF Research and Evaluation 2020, collecting quality research and evaluations from 2 ongoing research exercises, the Best of UNICEF Research and the Most Influential Evaluations. In the current global political climate, evidence, facts, and objective assessment are absolutely more needed than ever to help enhance the rights and well-being of the world's children and to ensure that we achieve maximum value for money for children with every dollar spent. Researching the changing world around us and evaluating progress towards a better world are indeed 2 sides of the same coin, both critical to reimagining future. The BOR webinars aim to jointly promote the 2020 winners and enhance the visibility and uptake of their work, both within UNICEF and of course also externally. The BOR webinars, let me instead say that I'd like to now say a word on the 3 BOR research winners and why they actually were selected. The research review panel selected 3 winners, which represent 3 different regions and score highest on most of the criteria which have been established. Italy, on unaccompanied and separated children in their transition to adulthood in Italy. The East Asia and Pacific Regional Office on the use of social media by children and adolescents in East Asia. And of course, Uganda, on strengthening community linkages to Ebola virus disease outbreak preparedness in Uganda. The winners were deemed outstanding in terms of highlighting structural discrimination and violence against children and adopting a rights-based approach. And they give voice to children and communities. They were also exemplary in engaging local institutions and communities in the research, allowing for ownership, capacity building, and policy and program impact. So now let me quickly turn to our excellent Uganda winner. Today we award and feature the winning research from UNICEF Uganda, strengthening community linkages to Ebola virus disease outbreak preparedness in Uganda, anthropological research on the sociocultural context of EVD in the most at-risk districts in Uganda. This research aimed to investigate community dynamics and cultural factors that may affect health-seeking and preventive behaviors by identifying possible areas of cultural resistance to information and by assessing the appropriateness and acceptability of Ebola prevention and control activities. The study ultimately informed culturally sensitive Ebola preparedness planning, including public health messaging and social mobilization around protective health behaviors, and particularly in high-risk border areas. So why did this study win? Well, the reviewers commended this excellent piece of research for the participatory approach, appreciation of cultural diversity and human rights, and engagement with local communities and agencies. And they noted important additional strengths, such as its transparent and ethical methodology and its well-substantiated conceptualization of the research purpose. The potential for impact is strong, since the findings are highly relevant to the development of policy responses in the ongoing COVID-19 pandemic. Establishing linkages with communities is a critical response strategy. This study also offers deep insights into how violence embedded in unequal social structures determines community responses. And the findings show that if public policies to control and prevent epidemics are not cognizant of these dynamics, they're likely to do more harm than good by exacerbating pre-existing inequalities. So with that, and now it gives me immense pleasure to give this award to our winners in Uganda. And needless to say, I would have loved to be able to present it in person. And this is the award, which will be coming to you in some format. Again, I do wish that I would be able to actually bring it myself. And the congratulations go to the research manager, Mandi Chikombero, the C4D specialist, UNICEF Uganda, and the government commissioner, Richard Kabanda, Commissioner for Health Services, Uganda Ministry of Health, Department of Health Promotion, Education and Communication. Huge congratulations to you, and let's give you a big, big hand.
Fantastic. Thank you very much, and congratulations. Very well deserved. Mandy, Table, would you like to, either of you like to react? Maybe Mandy, actually, let's go with Table first. Please go ahead.
Thank you, Kerry, and Golera, thank you and the whole team. And of course, on the call, there is Benjamin Ekla, whom we have met in several places, and the rest of you. As Uganda Minister of Health, we are happy, we are proud, and of course, it doesn't mean our sole effort, but working as a team, because when you look at the social context of our countries, it's a bit complex, and to win such an award of recognition of our efforts is really great for us. We know that what we are doing is not going to waste. And of course, Mandy and the whole CD4 team have been very supportive since in these public health emergencies that are befalling our country from time and again. So thank you so much. And of course, you're already aware, now Ebola is again in DRC Congo. So we are going back to square one, but of course, using the lessons learned from previous outbreaks, which have even led to the award, this award. So thank you so much, and God bless you.
Fantastic. Thank you so much. Mandy, anything that you would like to say before we move on to the presentations and the video?
Sure, just to say thank you very much for this award. It's really such an honor. And as Table has just indicated, it was really a collaborative effort of us supporting the government of Uganda to do this research. And it has set the bar quite high for us as we're now sort of looking at this as a standard for the evidence generation as part of our preparedness and response for all health emergencies. So thank you so much for this award. It's really quite meaningful to us. And thank you to all who supported this, the researchers, the enumerators, everybody who was part of this process. Thank you very much.
Fantastic. Thanks so much. So before we move on to the presentations, let's see what all the fuss was about. Celeste, could you put the video up, the short video? It will give you a short snippet of an overview of the project.
My pleasure.
So the overall importance and purpose of the research was for us to have a better understanding of the context in which we were working in trying to raise awareness of Ebola, EVD, and trying to get people to pick up behaviors such as hand washing and just a general understanding of some of the risk factors of EVD. There was high awareness, but it wasn't necessarily translating into knowledge. And there were some myths and misconceptions and just misinformation that was floating around. And we just wanted to better understand some of the social cultural factors and dynamics at play. There were a number of key findings. People prioritized their livelihoods, so getting by, making a living, over perhaps some of the health messages that we were giving. So people would continue engaging in some risky behaviors as long as they were providing them with a livelihood. We also found out that there were some really unique caretaking practices and preferences, including the general preference for cultural healers, traditional healers, and religious healers, as opposed to the more formal medical healing. There were also some interesting gender dynamics, with men still really having quite a lot of influence in terms of some of the care-seeking behaviors that were happening in their households. There were some unique burial and funeral practices that came up, and just the identification of some key informal groups that we had not necessarily focused on before. These came out during the research. We used the research findings that we got to tweak some of the programming that was ongoing. And this included programming that was happening within the communities, so community engagement, where we were now targeting some of the informal influencers. We were also able to use these findings to better inform some of our media campaigns, as well as do better targeting of some of the most vulnerable groups within the communities.
Thank you, Celeste. Fantastic. It's a great reminder of why it was such a well-deserved winner. So now my pleasure to hand over to Table Pekata, who, as you heard at the beginning, is the Assistant Commissioner at the Department of Health Promotion, Education and Health Communication at the Ministry of Health in Uganda, who's going to give us a short overview PowerPoint presentation on behalf of his colleague, Richard Kobanda. So Table, over to you.
Yeah, thank you so much, Kerry. So, good morning, good afternoon, and good evening from Uganda. So I'm just sharing a presentation on behalf of Richard Kobanda, who's the commissioner. I'm the next in line. So when it comes to public health emergency, I'm the co-chair. Is the chair of our pillar, the risk communication, social mobilization, and community engagement pillar. So I'm the co-chair. So we work as a team, of course, with our Mandy and her team. So I'm just giving a snapshot of what happened, the Ebola disease preparedness and community engagement, government of Uganda's perspective. So On August 1st, 2018, an outbreak was confirmed in the DRC Congo, which is just our neighbor on the west. So 22 districts in Uganda were put on high alert. You find that we have 71 points of entry or points of crossing on the DRC-Uganda border, which made the risk of EVD importation very high. So when you look at that map, and most of our borders are porous, so most of the crossing are not necessarily designated immigration controlled crossings. So they are no more village crossings. So there are very many. So we use the socio-ecological model to design our risk communication, social mobilization, and community engagement strategy to ensure comprehensive focus on all critical areas of SBCC action at different levels and beyond the individual, because an individual never lives in isolation. So we utilize those constructs of the same to make sure that we design our interventions and messages accordingly. When you look at our framework for action, we had some, ours is a pillar, but we had some 5 sub-pillars. One on public awareness, the other one was social mobilization, the other one was community engagement. Then we had the evidence generation, monitoring, and evaluation, which is important, which led to this award anyway. And then we had capacity building, because as you undertake this response, there's need to build capacity of the different systems at the different levels. So under public awareness, we had the message development and production of IC materials, basically the print, and also we had some electronic products, which were also developed. So we had the mass media promotion campaigns. We were working with the public relations unit of the ministry in order to make sure that there's regular dissemination of information to the public. Then we work with the social media. We had the call center, Ministry of Health call center, and of course the U-Report, which is also supported by UNICEF. Under social mobilization, we work with the different influencers and different respective institutions, because we wanted everybody on board to move together. Yeah. Then the other aspect was to use also informal influencers, because the other formal ones are those ones which have designated offices, but then there's those informal influencers who have a gathering, they respect. So we try to utilize all of them using their networks and groupings. So under community engagement, we had effective dialogue with the involvement of existing community structures to achieve community collective responsibility and action. So we had to go to the ground, work with our district teams to make sure that they go down to the different levels. And some of the activities have been shown in the short video, which has been just shown previously here. So, so that's where we went. So now under 4 was evidence generation, monitoring, and evaluation. So here we had, of course, a number of support supervision visits to the different districts on that side of the border. Then we had CAP studies, a number of them anthropological studies, and of course we documented human interest stories, because this is a key area for UNICEF. And of course we also treasure it as government. Then the last one was capacity building, and we made an effort to strengthen systems to achieve effective communication and efficient use of existing communication channels and resources. So just to look at the how we did the work, we decentralized the coordination and action, because we could not do everything at the center. So at the center, we had the risk the RCSM SE coordination at national and district levels, and we had the subcommittees at the district level, and of course, what they would use at the height of the outbreak. Of course, they would have weekly meetings, but as time went on, we ended up having maybe fortnightly. But one of the key tasks they did was partner mapping, use the 4W matrix, and of course the meetings I've mentioned. Then we come up with a common framework for action, which was used to develop the EVD strategy and implementation guide at national and district level. Of course, common activities also and aggregated outputs. One, we had the EVD posters, flip charts, leaflets in English and local languages. By the way, we have a lot of local languages. Uganda is multi-ethnic, even on just those districts bordering, which were at high risk. There were a number of languages where we had to translate. And of course, when we generalized the translation, we had to go back because some of the communities did own the languages. So it was a bit a challenge. We have what we call the village health teams. These are the sort of community health resource persons in the community who are volunteers. So we trained all of them on EVD prevention, reporting and control. And of course, they were also used for surveillance, community-based surveillance. And we equipped them with key messages to disseminate to the community. We used radio spots and talk shows on all the local radio stations in that region. We oriented the religious leaders, teachers, and other categories of cultural leaders as well. So sorry for the typo. We also undertook interpersonal communication through household visits, especially by these VHTs and the local council leaders. We have what we LCs. These are now also the local leadership at village level. So we also formed community group meetings at primary schools, especially as you saw, to teach them on hand washing, especially places of worship. We took advantage of places of worship, markets, taxi, border. These are motorbike cyclists who tend to ferry people, and of course the bus stops. So coordination of all these activities was, like I said, at national and district level. And at national level, one of the things we did, of course, was stakeholder coordination. And one of the tools we used to do this was the 4W matrix. We held national level risk communication meetings. And of course, we also feed in the national task force meetings that were also being held at the center. We developed the Ebola EVD risk communication and community engagement strategy, like I've already mentioned. And from that, we were able to develop some products, the risk communication materials and messages centrally, and these were shared with the districts. And in order to customize them, we had to translate them in their local dialects. We also obtained relevant social information, including development and preparation of CAP surveys, anthropological assessments, and rumor tracking systems were also put in place. At national level, also, we did partner mapping and resource mobilization. When it came to the district level, they also did local partner mapping because each district has its own partners who are supporting their efforts using the same tools, the 4W matrix, and of course, having regular risk communication meetings, and also sitting the same team on the risk communication team, also sitting the district task force. So we are able also to identify key audiences in the districts whom they would make special targeted interventions, adapted, reviewed, translated into local language, and disseminated targeted messages for the various intended populations. We implemented community engagement activities because this was now on the ground, provided feedback and rich revision of community engagement activities. So it was that cycle. So whenever we got feedback and we found gaps, we are able to refine our strategies and then produce better products. And of course, we held cross-border advocacy meetings. When you look at Kasese as a district, it has a busy cross-border point of boundary where people move in and out for business and trade. And of course, as Mande alluded in her video, it was encroaching on their livelihoods, and it was very hard to contain. But so we had to meet, and you know that Uganda is, our national language is English, the other is Francophone. So there were a lot of those dynamics, but we managed to hold some of those meetings to make sure, especially the local leadership in those areas. What were some of the key challenges? Untimely access to EVD funds across the district to implement risk communication activities. Yes, we managed to secure funding from UNICEF to disseminate to our districts, but some of the districts had challenges with their accounts, also pending accountabilities. Of course, this is now the financial management component where funds cannot now go to the account when there is another pending activity for maybe education or although this was an emergency. So that was also a key constraint. Quality of reports. So there was inadequate mechanisms of capturing real data on people reached by by categories, e.g. how many religious leaders were reached, how many teachers, how many school children, how many cultural leaders. So the mechanisms were not well set to capture so that you can easily quantify the numbers and the impact done. There were also competing priorities in the districts where EVD were preparing for EVD and the disease was across the board. These people also had other ongoing issues which they felt were a priority. But of course, as a country, we needed to protect our borders so that Ebola doesn't cross. Then there was partner exit. Of course, this was due to the long period of preparedness. We took long preparedness. There's that fatigue. Also, the same fatigue happened in the messages, complacency and high cross-border movements, interdependency was also noted in most communities. And of course, like I said, alluded to earlier, we have too many cross-border points, which makes targeted risk communication very challenging. I remember a case in point, we had to make banners for the different border posts, but when you interface with the districts, we are generating too many border posts, and of course it became very difficult. Where do you hang them? Some of them are informal, some of them are just small bridges, so you cannot pin up a banner. So it was a bit of a challenge. But of course, all these people were crossing, either jumping a river or a stream or a small bridge, all needed this information. But this was also a challenge because there were many informal border points. So key recommendations for improving Ebola preparedness. One of them is regular assessment and briefs to all on the risk at hand. So there is to emphasize that Ebola can be spread by anyone, and that's the stigmatization of migrants from the DRC. Of course, because of the civil unrest in DRC, we continue getting all these migrants from DRC. And like now they say there's Ebola in DRC, there's a tendency of the communities in Uganda to stigmatize all Congolese that they are infected with Ebola. So that is something which needs to be handled prior to any outbreak. We need to have coordinated efforts. So there's the issue for establishment and facilitation of the RCSM mobilization committees at district and sub-county levels to encourage coordination and implementation of EVD activities. It's important to pay attention to local dynamics. This is key, critical, including to avoid conflict between fishing communities and authorities so that the preparedness efforts are not derailed. When you look at the map of Uganda, there were some water bodies, and the way they do their fishing business, communities from the other DRC Congo would cross on this side, but then because of the Ebola outbreak, there was what we call RDCs. These are resident district commissioners in the various districts would prevent that activity to continue. So it was bringing a lot of conflict amongst the communities, this side and also on the other side. So there's this aspect of also inclusiveness. We need to capture concerns and address these from different people by gender, age group, vocation, or location. E.g., effect of chlorine on pregnant women was feedback from the community. Yeah, because they felt that this is a pregnant woman who is special because how do you spray her with chlorine because you are killing the Ebola virus? So they felt it was a bit insensitive. So these are some of the things which we need to address. We need to involve the young people. I think we realize even in other viral hemorrhagic fever outbreaks like Marburg, we realize that the young people feel that they are left out and that they are not at risk. So we feel we need to design youth-friendly mobilization activities to have the young people on board. After all, they are energetic, they are dynamic, but they need we need to raise their risk perception that they are also equally at risk like the other population. We need to engage other non-health sector players, like the district education officers, district community development officers, agriculture officers, and all these other people. Yeah, we need to establish databases of trained cadres for quick deployment. This is critical. And we need to have strategic investment in risk communication and community engagement, and also to leverage on community health promotion resources. So ladies and gentlemen, thank you so much. That's what I had to share as a snapshot on our story from Uganda. Over to you, Kerry.
Thank you so much, Tablé. And I notice in the meantime that Commissioner Richard Kabanda has also joined us. So welcome, Richard. Thank you very much for joining us as well. Before we take, Tablé, could you maybe stop screen sharing? Thank you. Before we take questions from colleagues, let's move on and listen to Mandy's presentation. There are some questions already starting to come into the questions and answers session, but if you have anything else that you'd like to ask, please do start typing those now so we have a good selection when we come to the discussion. So before I hand over to Mandy, that's a very quick introduction. As I said, she is the Communication for Development Specialist with our UNICEF Uganda office. Prior to this role, she held several similar roles, both in our East and Southern Africa regional office and in our Zimbabwe office. And she also worked as a researcher with the Soul City Institute in South Africa. She has been an assistant professor of communication development studies at Ohio University. So very knowledgeable, very well based in terms of C4D techniques, but also knowledgeable of UNICEF processes. So Mandy, we would like you to carry on and love to hear from your side of the story as well about the partnership.
Thank you. Thank you so much. Yes, thank you to Tablé for a good contextual background that the study sort of happened in. And I think it's important to just highlight that the study happened as part of a larger research agenda that had included, at the time that the study was done, 2 CAP studies had been concluded as part of the preparedness work for EVD in Uganda. And it was really in response to some of the findings from those CAP studies, particularly that indicated that there were very high levels of knowledge, but this knowledge was not necessarily translating into, the practices. People were not necessarily picking up the practices. So it was necessary to try and understand some of the cultural dynamics in these areas, particularly because of the cross-border dimensions. These are very complex areas in terms of cultures. It was important to understand what was going on in those areas. So just as I guess a bit of an overview, so I'm just trying to move down here. Okay, so before I even get into, so the major aims of the study were to sort of understand, as I say, the social and cultural context of EVD prevention, transmission, and just to inform the preparedness. We wanted to really highlight the community dynamics and the cultural factors around people's health-seeking behaviors and preventive behaviors. But also informing on areas of cultural resistance. Why were people resisting information that they were getting? What were some of those barriers attitudinally that we could work around in our messaging? We wanted to find out how best we could leverage any cultural assets in support of our risk communication for EVD, as well as establish how we could achieve cultural appropriateness and acceptability of recommended practices, but as well as some of the EVD prevention and control activities. So the major research questions of the study really had to do with, what were some of the practices, the religious, traditional and religious beliefs in the areas that would have an impact on preparedness and response. We wanted to understand how local, district, and national level efforts were viewed by communities. How were they received? Were they in a positive light, or there were some challenges there? We wanted to find out what could be leveraged to make people more receptive to the messages and for uptake of recommended practices, as well as to understand just aspects of the social, political, and economic context that had a bearing on EVD preparedness in the region, in the districts bordering the DRC. So you'll find, as Tablé was explaining, that the proximity to the DRC meant that the communities there would intermarry. There was a lot of trade. There's a lot of intersocialization. You'd find that traders sometimes went into the DRC as many as 4 times a day. There were very busy trading areas and trading markets around the borders, but also the livelihoods in the areas included some fishing communities that had some very unique elements that were picked up by the study. There were traders that were, carrying on exchange for access to basic services. In addition, there were some religious beliefs and practices that came up, including, you know, the syncretic religions where people had multiple beliefs and doctrines that were sort of sometimes mixing spiritual elements as well as factual elements, but also from a supply side, just inadequate sanitary facilities at key points of convergence, such as markets and the border points. Some norms, even norms of greetings, were picked up by the study as having an impact in the spread, or at least the risk factors for EVD, communal eating, as well as just, you know, the close proximity that people had at events such as market days and so forth. I know in some of the border points, there was as many as, you know, over 20,000 people would be crossing into the market. So and these people would be really overcrowded and in close proximity. So these were all factors that had to do with you know, they were relevant in terms of messaging around EVD prevention. Some of the cultural beliefs, as often happens with cultural beliefs, really they were very emotive as a foundation. So people were holding on to them for emotional reasons. There was also quite a bit of dependence on others to make key decisions. We found out through the research that you know, people were turning to traditional healers as the first point of contact and not necessarily the formal health sector. There was also a lack of trust. There was often sometimes even some conflict between the refugees, the areas, as well as the host communities, and a lack of trust sometimes between the community members and the authorities. And this we managed to find out through a number of methodologies that we used. The study primarily used document reviews. We also did about 87 key informant interviews and about 25 focus group discussions with different segments of the communities, with women and men and, you know, religious and cultural leaders, local leaders, local stakeholders, traders, as well as representatives of some of the border associations, the bikers that sort of transport people and goods from Uganda, the DRC, and vice versa. These are some of the methods. We also employed observation methods, where our researchers participated in meetings that happened in the communities, but also meetings that were organized by the district task forces that were meeting, as well as some informal meetings among traders and so forth. So it was a range of research methodologies that were employed to actually find out some of these things. So in terms of some of the perceived threats that we saw, remember we're thinking of, you know, what could be perceived as a sort of a challenge to some of the efforts that were happening for EVD. There was some denial that EVD was actually present, and there was some resistance. A lot of this had to do with, you know, EVD being viewed as a foreign risk. It's something that was brought from the outside. And then there's just a general mistrust of interventions, with some groups feeling as if, because of previous experiences, that this was probably not necessarily, it was not real, or that there was some other agenda to all the efforts that were going on for EVD. There was some refusal by communities to change long-term norms and practices. Again, this is something that we learned and mirrors some of the findings from much of the research that happened in the West Africa EVD outbreak in 2014-15. There was a general frustration at the lack of services. But also and this often translated into people sort of resisting and deliberately resisting the messages and not trusting the mobilizers that were trying to give information and so forth. There was general apathy and sometimes relapse with people. As I said earlier, there was high levels of knowledge of the risk factors and what EVD is, how it's transmitted, what are the symptoms, but sometimes there was some apathy and some relapse with people not necessarily demonstrating in their actions that they actually understand what the risk factors are. There was also mistrust, again, as I indicated. The first point of call is often the religious or traditional leaders or the local people, as opposed to the formal health system. There's quite a bit of mistrust there. And as Table indicated, message fatigue had set in by the time we'd actually started the study. There'd been quite a bit of work, as Table indicated earlier, that had already happened in these areas. So people had heard the EVD message for quite a bit of time, and we got indications of some message fatigue, which was a challenge for us because we really knew that we'd have to use the findings of this research to revamp our messaging, which we successfully did. And then, of course, the failure to access desired services was also something that came up in the findings and as a threat as well. So again, I think in terms of some findings, if you think of some of the gender dimensions, we found consistent with other studies that had happened, again, in West Africa earlier, we find that women were perceived as more vulnerable and that this vulnerability was sort of underpinned by norms, particularly relating to caretaking behaviors. We found out, that pregnant women were also quite vulnerable, and this was this confirmed some other studies that had shown that EVD fatality among pregnant women sometimes was as high as 95%. So there were some clear gender dimensions there, particularly with caretaking practices. And then in terms of the fishing communities, a lot of these districts, actually, the major livelihoods are from fishing. We found that often there were some conflicts with authorities, long-standing conflicts that came up, conflicts to do with exorbitant loans that fishermen could access, as well as restrictions on fishing. There's some areas when we had restrictions in terms of fishing for environmental reasons. So because of this, I think when the work on EVD started, all the response work started, and then the preparedness work started, there was some resistance with people saying it could be just the authorities once again just trying to sort of keep us poor and in poverty and things like that. So there was some resistance to all the official messages that were coming out. So again, we also asked, we looked into who would be the best people to give messages in this context, given all the challenges that we've shared. And we found that generally, again, the authorities, government, health workers, the army, security officers, customs officers, remember these are borderline areas, these were generally not trusted. They were viewed with suspicion, they were viewed as carrying some other agendas, and we found instead that the most trusted were the religious leaders, some of the NGO workers, private health workers, local leaders. So people within the communities were trusted as people that were actually living in the communities and not coming in, bringing in an official or authoritative message. So again, the challenge for us then would be to take this information and see how best can we sort of leverage some of these stakeholders, some of these people in the communities as we do our messaging. So as we look towards, as I indicated, we used the findings of the study to intensify and scale up some of our community engagement using some groups that we had not used in the past. For example, on the left on this image, you'll find a border rider. These were key because they, as I said, they are the ones that go across the borders, carrying people and goods, sometimes carrying dead bodies, as we found, and actually successfully hiding dead bodies as people returned to their ancestral homes to carry out their burial rituals and their burial practices that were that they were quite attached to. Some of these including things like, washing of bodies, spending a night with the body in the home, and so forth. But so we found out that this had been a neglected group that potentially was quite powerful in terms of reaching people, and also that they needed information on the risks that they were also engaging in as they were going between the two countries. On the right, you'll find one of our Red Cross volunteers sort of working to do some mobilization. And we found that, again, people that were within the communities were really powerful and were trusted to actually give the messages. So we had to step up and intensify a lot of the community engagement. Up to this point, a lot of our engagement with these communities had been using a lot of the mass media. We'd been using a lot of, I think Tablet had indicated, banners and information. After the study, we realized the importance of actually scaling up community engagement, and we did so successfully. So just in ending, I think in terms of implications for further study, but also really practical implications. We have learned a lot from the study that we have actually applied to the COVID-19 situation. For example, I talked a little bit about the community engagement. That has been a challenge, obviously, with some restrictions under COVID, restrictions of gatherings and so forth. We've had to sort of think twice about, think harder about how do we engage communities using the same people. So we've also learned, for example, the value of having these community meetings at a local level. So the district level meetings have been really important for us to support as UNICEF. We found that we can try to merge mass media as much as we can and make it more interactive to sort of bring in the same elements that people get from one-on-one community engagement with local mobilizers. These are some of the things that we found. And this is just a final slide that shows even just using some of the teachers and training them as good channels of communication. These are some of the lessons that we have carried forward, even under the current COVID-19 pandemic. I'll stop here for now.
Fantastic. Mandy, Table, thank you so much for those presentations. A really good reminder of why this was a very worthy winner. We're running a little bit short of time, and I want to allow some time to answer some of the questions that are starting to appear in the Q&A. Please keep those coming in. But in the meantime, I wanted to hand over just quickly to my colleague, Ben Hickler, who is a behavioral sciences research manager, also at the UNICEF Office of Research in Argenti, but his background is in medical anthropology and social behavior change. So I asked him to get our discussion going, to just kickstart a few of his reflections. He was also one of the reviewers of this piece of research when it first came in through the competition, and to maybe get our questions up and running and started, Ben. So over to you.
Thanks, Carrie. And first, let me just begin by echoing the gratitude and the congratulations to Mandy and Table. We've worked together years ago, and I'm just thrilled. This is an excellent piece of research and important kind of applied anthropology in the context of an outbreak, of an epidemic, of a health emergency. Because we're short on time and there's just so much to say, I'll just try to kind of tease out a few threads that really resonated for me. Not only is this an exemplary piece of research that illustrates the kind of local sociocultural texture that's kind of shaping everybody's everyday lives and their behaviors in the context of a health emergency, but it really does illustrate some important principles and themes that I think are not only more widely applicable beyond this particular outbreak, but are maybe acutely relevant in our contemporary moment in light of this COVID-19 pandemic. And one of the most important points, I think, is that while this COVID situation affects everybody, it affects us all, it affects different people in very different ways. And so I think hopefully we can get into this question of equity and even some specifics around gender and marginalized communities in the Q&A. I think on the topic of equity, the main thing I would say is that what I love about this research is you're not only talking about equity to access to resources, not only, like all, I think, health emergencies, and we can certainly see it with COVID-19, a health emergency or an outbreak, epidemic, really brings to light all of these kind of social fissures and these structural chasms and structural inequities that really shape not only the experience of an epidemic, but the outcomes, which really can be life and death. But there's this sense also that really comes across in this research about equity in terms of whose voice gets heard, whose voice matters, whose knowledge counts. And I think a real strength of this work is that you make sure that the voices of people who are really directly affected matters and is listened to, and it counts in terms of shaping the response. And this is not, what it demonstrates is that effective solutions aren't always just the technically sound ones, but they don't necessarily only have to be innovative, but they have to be equitable and they have to be inclusive. And these principles of dignity and inclusion and participation, they're not just about abstract rights. It's really about operationalizing evidence in action, and it's what makes research effective in terms of shaping an effective response in terms of really bringing about social and behavior change for good. And it's also about, building trust and making sure that people feel like they're seen and that they're heard, which I think is this critical component that too often is an afterthought, or it's not as prioritized as it maybe needs to be in health emergencies. I don't want to take up more time. I have a lot more that, of course, I would love to say because it's such a great piece of work. Some of the other themes that maybe if we do have the time that I'd love to hear more about is, and that I think are not only relevant for this particular case study, but also relevant for our contemporary situation and for other contexts, is the disproportionate impact of these types of situations on women and girls. I think this question of gender would be something that I'd love to hear you talk a little bit more about. There's also some other themes like behavioral fatigue or message fatigue, being told the same things over and over again, and people find behavior change tiring. And then a related dimension, I guess, would be, on preparedness. How do you actually build those sustained structures for community engagement that aren't just one-off, asking people for something when you need it, but that really build mutual relations of trust and cooperation, and that are kind of true structural transformations in the relationship between communities and systems. So I'd like to stop there because I think we have enough questions, and I think I think who we really want to hear from are the people who are involved in producing this great piece of work. So if I may, Carrie, can I hand it back to you to go through the Q&A?
Sure, Ben. So thank you so much. With people's permission, hopefully we can maybe continue for a little bit, 5 minutes over time, because I'd like to give some space to questions, but also very cognizant that people have other meetings that they may well need to go to. So maybe let me hand the question over to Tablet or to Richard as well as here, if he would like to unmute. Keep your questions coming into the Q&A. But maybe to start with, to pick up on that question of equity that Ben just raised, but there was also a question from Camilla in the chat, very much about the same thing, about whose voice counts, how do you go about making sure that the findings are representative of various cultures and that some don't get prioritized over others. So Tablet or Richard, would you like to respond to that one to start with?
I think it will be fair for members to hear Richard's voice. Over to you, Richard.
Thank you, Tablet, for the presentation, of course, and to all the panelists. My apologies. My colleagues have been able to elaborate some of the key aspects.
We can't hear you, Richard. Richard, we can't hear you very well.
The question on whose voice, at which point in time do you engage with these members of the public? It depends on the issues at hand. And of course, you are aware that most of our countries in Africa have different cultural perspectives. And of course, so it depends on the issue that you need to address and the proper identification of the key influencer in a particular community. Of course, we have been able to learn a number of things that for public health emergencies and literally for all public health interventions, all individuals are equal when it comes to influencing the community. So it depends on who you select and at what point in time do you decide on the kind of person. So we need to take all individuals. We have learned that all individuals are equal, depending on what you may need to achieve. And I think we need to carry on this going forward. So, for example, we have also been able to carry on some of the good attributes, giving an example of, say, COVID, where I would say that in Uganda, we're able to even identify, I would say in quotes, a prostitute, to be able to engage fellow prostitutes who were actually so much engaging with the truck drivers, to be able to talk to them, and she was over our mass media institutions, to be able to engage with people, because at that point in time, we knew that this person is the one driving the agenda. So that has been a key lesson for us. And I think that we need to carry that forward.
Fantastic, thank you. And maybe picking up on your response just there to go over to Table, because another question that a lot of people have been asking, almost inevitably, I guess, is what are some of the lessons or the most important lessons that we've learned from this piece of work that are actually affecting how the government responds to the current COVID pandemic?
Is it over to me? Okay.
Please go ahead. Yeah.
Let me make an attempt, of course, Richard and Mandy, since we are in the same place. I think one of the lessons which we have picked over time is working with the local leadership, because we have the different structures at the national level, at district and sub-district level. So working with the local leadership has been very important, because trying to utilize the existing structures, that has been very key in driving the agenda in the initial phases of responding to an outbreak. Also, engagement of non-health stakeholders, because a public health emergency like Ebola is health related, but then if you want to reach, to have a wider reach, you need to go beyond just the health systems. So to work with the non-health structures and non-health stakeholders and be able to drive the agenda forward. Then the other thing was being to the partners. I mean, we have just even picking an example of the COVID, which we are in. You found that when we were in a problem, everybody came on board to support. It's just because we had a very good relationship with the partners we work with, the non-health stakeholders, and the different leadership. So there was that political will at the different levels has been very key. So let me just stop there and leave some for Richard. Thank you. Over to you, Kerry.
Thank you. I wondered whether Mandy wanted to come in to respond to that. Also, I mean, it relates to other questions that have come in from the chat. So Judith has asked one about coordination at the district level, and which is perhaps challenging. And maybe you'd like to wrap that into any answer that you give.
Yes, I think I was just sort of trying to respond to some of the questions in the chat as well. Certainly in terms of the lessons, I think, and some of the findings, the use of local research assistants who are very familiar with the areas and things like that really opened up spaces to us that we would not necessarily have had access to. In terms of coordination, I think from our perspective as UNICEF, direct support to local governments was actually one of the things that aided the coordination, because that also came about with accountability for the coordination efforts and some of the activities. So that was a lesson learned, and that actually worked well, because prior to this, a lot of our support had been going to sort of national level, but we actually brought it down further to local level, and that actually worked very well for us.
Great. There's another sort of related question here from Esther in the chat as well, talking about the cultural issues. And she's asked whether Ebola had additional costs associated with burial similar to what COVID has. If so, how did the project encourage people to report cases or deaths at home if IPC and management of dead bodies would cost more? I don't know, maybe back to Table or to Richard to answer that one.
Maybe come again, it wasn't clear.
Sorry?
Kerry?
Yes?
I didn't get you very well. The question wasn't clear to me.
Okay, let me see if
paraphrase it, please.
Yeah, I'm just wondering whether, could we unmute Esther to ask it in her own words, Celeste? Is that possible? No, okay. So she's asking, I mean, I'll see whether Esther can come in, but she's asking about if there are additional costs associated with burial from both Ebola and COVID. How did you actually encourage people to report those cases and the deaths at home if it was true that management of funeral costs and dead bodies would actually cost more?
Okay, I've seen the question, but you see, it falls under case management pillar.
Yeah.
By your team, yeah. So risk communication, apart from disseminating messages on risk, that if somebody has died of Ebola, you are not supposed to touch, must report to the nearest district task force coordinator, and then they handle the burial so that they can inform the burial team. So in terms of course, I can't not in the position to answer that one. Yeah.
Okay.
Can I come in to clarify?
Sure, please go ahead.
Yeah. So I was wondering. So we know that under COVID, for example, families have to incur more costs to bury appropriately. You have to buy a suitcase and other things, and that takes money. So the additional cost is typically a barrier to report cases. So from a risk communication perspective, how did you communicate that balancing the costs, or encourage people using risk communication to report deaths at home, even if they knew that reporting a death at home may necessitate additional costs to bury? Is that clearer now?
Yes, it is. I think when we go back to Ebola per se, we didn't have any case in Uganda. These were foreign cases. I think there were just 3 which were repatriated to DRC Congo. And when we go to previous Ebola outbreaks, it was always the government handling the burial costs. So the community will not be involved. So I think that's the difference with now with COVID, because we have now registered a number of deaths, and of course some are happening in different areas of the country. Here the cost tends to be now on the families, but in the initial phase of the response to COVID-19 in particular, of course, the government was footing that. Yeah. That's the little I can respond to. Over to you, Carrie.
Fantastic, thank you. We've only maybe got time for a couple more questions before we close. So I just wanted to maybe go back to Mandy to pick up on another question that people have asked about trust. Not so much in trust in facts, but trust in the sources of information and sharing. And again, thinking back to the current situation we find ourselves in, are there any lessons there in terms of how we can improve trust for vaccine uptake, for example? Mandy, over to you.
Yes, yes. Often the source of information sometimes is even more important than the information itself, isn't it? And I think this is something that we found found out the hard way in some cases, because we had spent quite a bit of resources actually giving messages from authorities and so forth. So you'll find that in terms of lessons learned for COVID right now, a lot of our messages are actually being given by people who have gone through COVID. We've got a series right now that's going through on COVID testimonials from people who survived, people who've gone on mild cases of COVID, but these are everyday people that communities can relate to. And Mr. Kabanda also gave an indication, I think Richard earlier on, of also engaging some lesser known groups or groups that we don't always utilize, but have quite a significant following and have some credibility within their circles, because they are better than it does. So that was really a massive lesson for us, and we've taken that forward for COVID-19.
Fantastic. In which case, I'm really sorry. I think in the interest of time, we're going to have to draw this to a close. So many interesting
and I think maybe
questions. Mandy, please go ahead. Mandy, did you want to say something? No,
it's fine. I was just going to add that, some of these are really unlikely, but it's fine. I think it's okay. We'll end.
Okay. So again, thank you very much for everyone for staying 5 minutes over time. Apologies we didn't get to all of your questions, but I wanted to take the opportunity again to both thank all of our panelists today, to thank everybody who tuned in to listen, and to thank everyone who you didn't meet behind the scenes. So Celeste, Emanuela, and several other colleagues who are also online to support us. Manuela put the link to the Best of UNICEF report in the chat. So if you'd like to see more information about this particular piece of research, please do go ahead. And we look forward to welcoming you to the third episode in the seminar series in March. We'll be sharing details in due course, but congratulations to all the team who were involved in this once again. And thank you very much. Bye-bye for now.
Congratulations again, and thank you, everybody.
Thank you, Carrie. Cheers.
Thank you.
Well-deserved prize.